Okay, so what does the audience think about this? So the question again is medical management versus early intervention plus medical management, severe to our minimal symptoms. Who said just do medical management? Raise your hand. Okay. And who says early intervention? Raise your hand. Okay, well, we have Dr. Desai. He's gonna comment.
Thank you. That was very good, Rhonda. She lives. Her office is 3 doors from me, and her house is 3 doors from me. So she's my neighbor and very good friend. And occasional, she brings me back and forth from work. So I don't want to, But there are things you can and you should do in asymptomatic TR, similar to on the left side, that could help potentially identify higher risk patients that may need an operation. So Tom Wang, our colleague, myself, Emmanuel, who's now at Yale, we published a paper a few years ago in more than 300 asymptomatic severe TR patients in whom we diligently measured RV regurgitant volume and RV free wall strain. And these are all asymptomatic patients. So at baseline, if your regurgitant volume was more than 50-ish and negative 20 of free wall strain, if these patients, beyond this threshold, if they were operated early, they had better outcomes, at least at the Cleveland Clinic. So there may be, on one hand, we have these large multi-center randomized non-sham controlled trials with KCCQ that don't show anything. But so we need to be looking at a broader picture. So I do think there is a group of asymptomatic individuals that may or may not be asymptomatic. And just making a comment, and I want to hear your thoughts and to stir it up.
I'm actually glad you brought that paper up. I actually had it in my talk initially, and I had to take it out just because of time limitations. It was nice in that it was a few thousand patients that were screened out of the echo data. It's very interesting. Most of the patients that you guys looked at in terms of asymptomatic TR actually ended up being screened out because they had atrial fibrillation or prior diagnoses of heart failure. And so that actually screens out a lot of the patients for functional TR. So I'm not sure. I think at the end of the day, we went down from a few thousand patients. I think there were just a few hundred at the end. So I think it's great that we're trying to understand what to do with these asymptomatic patients. And I think that, again, we do have a point where it is too late to intervene on, but I don't think that we have data to support at this point, knowing long-term outcomes for people really in that asymptomatic group. I don't know if you have a comment, Steve.
Not about that specific paper, but just a point that I wanted to make that I didn't yet make is that when you treat the RV well, you treat the LV. Right? You take away the septal shift. That gets better. You actually can improve LV diastolic function because the septum's a third of the LV. Now you're not fighting the septum. The septum can relax if you have a good tricuspid effect. So you're improving LV diastolic function. You're improving LV systolic flow because you're increased flow in preload. So I think we're in this mindset that it's an RV-only intervention, but it is not. If you do it well, it's an LV effect that we can measure and rely on. And if we had something that we could do to somebody to say, I'm going to increase your forward stroke volume by 15 to 20%, we would do it all the time. But I think when you do a good procedure, that's actually what you do.
Excellent debate, guys. Thank you so much. We're fortunate we have a lot of images in the room, and I think we need to think about that spectrum of disease and do a better job of detecting those with RV dysfunction earlier, because I think we have this chronic issue that we undercall how bad RV dysfunction is. Many of our parameters, TAPSE, S prime, free wall strain, are really looking at longitudinal function. We miss out on those RVs where the radial function has started to decline. I'm an echo lover. I'm an MRI reader. I think the multimodality piece is important. We have a limitation on resources. Not everyone can get an MRI. But I think as we look at the RV, often these patients have huge RVs, they've got airways disease, it's challenging to get good acoustic windows. But we've got to do a better job at detecting RV dysfunction earlier in the piece, because then I think that places them further along the spectrum than what we might necessarily think, and just interested in your thoughts.
Yeah, and there's a question from the audience. It's actually a nice, that follows nicely from Christine's comments, and that is there a role for RVPA coupling? So maybe before you respond, you could consider that in your response as well.
Yeah, I think that's a great point, Christine. We really need to understand how to, risk stratify these patients, and I do think, I truly do, agree with the fact that we're treating these TR patients too late, and I think the question really is, what is the optimal timing of intervention? Because once we start seeing the RV dilation and the RV dysfunction and the RVPA uncoupling, we've kind of gotten to that part of the disease process, and I think whether you're asymptomatic or symptomatic, we're already very late in the disease process by that point. So I think the question is, for me, when I think about this, what are the upstream markers that we can start looking at to understand which patients are going to be progressing to that late stage of, RV, dilation and dysfunction? Because I think that's going to be the real target, that if we can stop things before it gets that bad, again, asymptomatic or symptomatic, I think then we have an opportunity to potentially improve long-term outcomes. And I think that's really got to be one of our big targets moving forward in the field.
Yeah, it's a great question, a great comment. I think part of it is the way that echo is applied nationally is a problem. I'm sure your center does, our center does. You get sent echoes from community hospitals, private labs. It's a 4-chamber view, and that's all you get of the RV. They're not RV-focused views. We know very well that the RV-focused view is required to truly see the dimensions of the RV, the size of the RV, to have any hope of a determination of systolic function of the RV. A 4-chamber only view is not enough. So I think there's a brand new ASC guideline on sort of RV right heart assessment, and that should be reviewed. But it's not the old days where we weren't going to... There was a long time, where we didn't intervene on the right ventricle anyway. So we did, the TEs were tricuspid drive-bys. You kind of pull the probe out, take some views. Nobody wanted to touch it, so why find it? Those days are gone. We have to focus on the RV and focus on the tricuspid valve, and that starts in the echo lab. So that's the main thing, is get better at evaluating the tricuspid valve. We also have to index the RV function for the setting that it's in. We accept the mitral, the LV should be hyperdynamic in the setting of significant MR. That's a healthy LV, should be hyperdynamic. But you can have wide open TR and an RV that looks kind of normal, but it shouldn't. It should be also hyperdynamic if it's primary TR. And if it's not, really banging away in somebody with a lot of TR, then that's a diseased RV. And we see that as soon as you do an effective T-tier without a bypass run or any of that stuff, there's no RV wall insult, simply taking away the easy afterload option, the EF drops, the RV plummets down 10, 15 points acutely. So you're not damaging the RV, you're revealing the RV. And I think that's the mindset, it's sort of hidden. The RV dysfunction is hidden by the effect of the TR, and we have to get better at indexing and recognizing a sick RV. All of us do.
Great. So I have one quick question. As everybody has pointed out, most significant TR is secondary TR, but there are some patients with primary TR. And Steve, you pointed out nicely the challenges of defining whether or not somebody is symptomatic, and especially in the universe of patients with secondary TR, a lot of what it's secondary to is left-sided disease, for example, so it becomes really difficult to sort out whether the TR is causing any symptoms that the patient might have. But the question to both of you is there any role for stress testing in these patients? We know in AS that a large number of patients who present themselves as being asymptomatic on formal stress testing, roughly a third of them turn out to be not hit the goals that you would expect for someone of that age, sex, fitness level. Any role maybe in patients with primary TR to decide whether they're symptomatic or not?
I think that's actually a great question, a great point. There's a very specific reason that in my talk I completely left out primary TR, and that's because primary TR is a whole different ballgame, right? The valve is the problem. And so I do question with severe primary TR, is there a role for fixing the valve early, right away, before the RV changes happen? And I think that's similar to what we see on the mitral side, right? With everything that we've seen in terms of mitral regurgitation is we think about primary mitral regurgitation very differently than secondary mitral regurgitation. If you have severe primary regurgitation, if you're symptomatic, you 100% need to be intervened on. If you're asymptomatic, there still is potentially a role and a benefit in terms of preventing downstream complications of MR. I think likely over time we'll probably see the same for primary tricuspid regurgitation as well. Because that is a state where truly the valve is the problem. So if I have a patient with severe primary TR and they say they're feeling great, honestly, a part of me probably does want to fix the TR. And so maybe we should be doing, assessing, truly assessing, functional capacity and doing stress tests and metabolics and things like that. And if things aren't quite normal, perhaps that is a reason that we should be thinking about intervening early. What do you think, Steve?
I think stress testing is an interesting idea. I think that the current culture, it would not add much benefit, only because we're getting referred patients so late. They're mostly functional, they're mostly sick, they're mostly the other end of the spectrum. They're grossly symptomatic, and you're trying to find something that fits. That's generally where the effort is these days. I think as we move down the risk strata to this patient group we're talking about that is truly questionably symptomatic, not on therapy, any therapy, then I think stress testing could become important, but probably for primary, because the secondary is so ubiquitous, and I don't know how you would index the stress test. I don't know what I would expect for somebody who's got LV dysfunction and pulmonary hypertension, and I don't know how to lay blame at the tricuspid valve, even with a stress test typically.
So as a segue to the next session, the most common, I see a lot of patients with constricted pericarditis, and the most common mimicker is severe TR with RV dysfunction. They refer for pericardiectomy, but they don't have that. They have severe TR with RV dysfunction. You have to be very careful, because if you do surgery for that indication, it won't be a good thing. But I want to thank the debaters for excellent session, my co-moderator, and Dr. Mackinson. You have 1 minute.
Thank you. Just quickly wanted to comment. Thanks for the debate. I thought it was excellent. There's some emerging data that perhaps it's as a compromise. It's that intermediate patient population that ought to be treated. And I think Becky Hahn and others have shown that if you treat too mild or too severe, too late on the spectrum, then the outcomes are not going to be as impactful as if you treat more of an intermediate patient population. And as a cardiac anesthesiologist, I'm reminded of the year-long research on the LVAD patient population, where the surgeons had the opportunity at the time to repair the tricuspid or leave it alone. And again, if you ask even 3 surgeons at our institution, they all had a different take on it. So we actually started randomizing patients towards a repair once they had at least intermediate or moderate TR at the time of an LVAD placement. That answer we still don't have either. So I think it's actually a surgical topic at times as well.
Okay, thank you very much.